Welcome, everyone, to our fifth Anne Klibanski Visiting Lecture Series. My name is Louisa Sylvia. I'm the Director for the Office of Women's Careers within the Center for Faculty Development. In today's session, Dr. Andrea Simpson from St. Michael's Hospital in Toronto will be talking about the gender pay gap and reproductive outcomes among women physicians. So here's a little about the Anne Klibanski Visiting Scholar Award. If you have not been to one of these before, this award was established during the COVID-19 pandemic as women were disproportionately affected during that time, given the additional childcare and household responsibilities. And so we capitalized on sort of the transition to this virtual world to offer visiting professorships and visiting talks in this virtual world, which we hope will help our women who find traveling potentially more challenging given these additional childcare and household responsibilities. And here's Anne Klibanski, which is named after this award is named after. She's the president and CEO of MGB and the former director of the Center for Faculty Development. She's also a very successful clinical researcher and a strong supporter and advocate for women. And these are visiting scholars to date. We've had 3 different cohorts, so 2020, 2021, and then 2021 to 2022. And then this current group now from 2022 to 2023. So you can see a great group here from across our institution and across departments of women who are doing outstanding work that we wanted to highlight and champion their work through this award. All right, so importantly, we are currently accepting applications for the award currently. So if you want to apply, the deadline is coming up on May 15th, and we really encourage you to spread the word about this wonderful award. It really gives women the opportunity to have virtual talks and be supported by senior faculty, to network and collaborate. And there's also peer mentoring that comes with the awards and other sort of coaching and other activities as part of the award. So it really is an outstanding opportunity for our women faculty. And these are the champions. Those of us who sort of help to support some of our AK scholars, we really want to thank all of them. They really kind of make this award possible. I mentioned this lecture series a little bit, but this is a part of the award, which is that it gives the opportunity for our AK scholars to give a talk in collaboration with a colleague, and that's Dr. Andrea Simpson today is one of our AK scholars, sort of collaborators and networkers. And that's why she's kind of come to us today to give this talk. So again, it's a great opportunity for both the AK scholars to do a lecture and also to, again, collaborate and network across other institutions, which is wonderful. And there's St. Michael's, which Dr. Simpson is where she is currently, I'm assuming, or in that vicinity anyway. Great. And then last but not least, I'm going to introduce our wonderful speaker today. I'm really looking forward to this. So Dr. Andrea Simpson is an obstetrician and minimally invasive gynecologic surgeon at St. Michael's Hospital in Toronto. She's an assistant professor at the University of Toronto and an adjunct scientist at the Institute for Clinical Evaluative Sciences. She's a clinical epidemiologist, and her research interests include access to health services, maternal and newborn outcomes, as well as issues pertaining to physician health and wellness. She's a Canadian Institutes of Health Research funded early career investigator and holds a Physician Services Incorporated New Investigator grant. She's active in both postgraduate and undergraduate medical education and has won a number of teaching and research awards, including the Council on Resident Education and OBGYN. And that's the National Faculty Award. And she's a team member from the Melbourne School of Population and Global Health for best research with a significant policy impact, which was entitled Addressing Gender Biases in Surgery Researchers. So without further ado, I'm thrilled as a psychologist and director of the Office of Women's Careers, I had Dr. Simpson here to speak on this topic. Thank you so much.
Thank you so much. I'm just going to pull up my slides here. So it's an honor to present to you all today. I do want to acknowledge the Physician Services Incorporated Foundation that has funded a lot of the work that I'm going to be presenting today. I would like to start with a land acknowledgement. So Harvard University is located on the traditional and ancestral land of the Massachusetts, the original inhabitants of what is now known as Boston and Cambridge. We pay respect to the people of the Massachusetts tribe, past and present, and honor the land itself, which remains sacred to the Massachusetts people. And I'd also like to acknowledge that while I'm here virtually visiting, I live and conduct my research on the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. So today I'm going to be discussing the gender pay gap and how it can exist in a fee-for-service system like the system that we have here in Ontario. I start with the gender pay gap because it is the most concrete evidence of gender bias in medicine, and the issues around gender bias that women physicians face throughout their careers can directly impact their decisions around family planning and the timing of family building. This in turn can influence their reproductive outcomes. Then I'm going to be discussing solutions to closing the gender pay gap and supporting physicians who are parents at any career stage. Note that gender is often treated as a binary variable in the literature, so many of the studies that I'll be discussing defines it as such. But understanding the experiences and perspectives of gender diverse physicians is certainly in need of further research. To understand gender bias in medicine, we have to understand the cultural and historical context. Women were historically excluded from the profession. This is Dr. Emily Stowe, the first female physician to practice in Canada. She was denied entry to medical school in Canada. The vice principal of the Toronto School of Medicine said, "The doors of the university are not open to women, and I trust they never will be." She went to the US to earn her degree and then returned to Canada to practice in Toronto. Although we have now achieved gender parity in medical school admissions in the US and in Canada, we still have a long way to go in truly ensuring gender equity in medicine. And it's the much needed cultural change that lags behind. While we acknowledge the more substantial difficulties that women before us experienced, I don't think that we can just say, progress is slow, we are where we should be, it'll take time. We need to have these difficult conversations now and think more creatively about how we can ensure gender equity in medicine. It's a well-established fact that female physicians earn less than male physicians. The disparity in annual adjusted salary is estimated to be as high as 20% in the US and 40% in the UK. The magnitude of the difference varies across specialties, but US data suggests that the disparity is widest in surgery, specifically orthopedics, the surgical subspecialties, and OBGYN. The underlying causes for the pay gap that have been put forth include the fact that women are less likely to enter the highest earning specialties. There are fewer women in leadership roles. They may have fewer years in practice, differences in practice type or style, the numbers of hours worked, and parental status. But even in studies where these factors are accounted for, a persistent pay gap exists. A population-based study using Medicare data performed here by Dr. Anupam Jina at Harvard evaluated Medicare data and found that even after adjusting for these differences between men and women physicians and using proxies for part-time work, 38.7% of the disparity remained unexplained. In addition, female associate professors were making approximately the same as male assistant professors, and female full professors were making approximately the same as male associate professors. So we undertook a study to evaluate the pay gap in Ontario's fee-for-service system. In our system, physicians submit claims for services rendered to the Ontario Health Insurance Plan, or OHIP. We are a public system, and OHIP is the universal single-payer plan for all Ontario residents. So certainly in Ontario's fee-for-service system, men and women with similar training who work equal hours and perform similar work should make approximately the same amount of money. And since the income gap was the widest in surgery, we hypothesized that earnings for time spent operating could be a potential source of the earnings gap. Our primary outcome was reimbursement per hour of operating time. So we used administrative data from ICES, which captures all physician billings through OHIP in the province of Ontario. We evaluated all in-hospital elective surgical procedures performed over 3 years. To calculate surgeon reimbursement, we used surgical procedure billing, so the total amount paid to the physician. And to estimate time, we used anesthesia billing, which has time units down to 15-minute increments so that we could estimate surgical procedure length. The surgeon's total earnings across the study period were calculated and divided by the total operative time to determine earnings per hour. We selected physician-level covariates associated with level of expertise and patient-level covariates that could influence case complexity and thereby earnings. We then looked at surgeon sex and remuneration across specialties, and then within specialties using a matched analysis. For the within specialty analysis, we hard matched on specialty and years in practice, and propensity score matched on other patient and physician level characteristics to ensure that it was the most apples to apples comparison possible. And then we looked at a few factors that we thought could explain the gap, which I will talk about later. So we looked at 1.5 million surgical procedures, billed by over 3,200 surgeons. Male surgeons were older and had more years in practice compared to female surgeons. And they also looked after a lower proportion of female patients. For the most common specialties, for the men, it was general surgery and orthopedic surgery. For the women, it was gynecology. 48.8% of women surgeons were gynecologists, and general surgery. Across all specialties, the unadjusted mean hourly earnings in the operating room are shown here for men and women, and the difference was $64.88 an hour. In multivariable analysis, women surgeons had lower hourly earnings than men, making 24% less than men per hour spent operating. And in our matched pair analysis, which took years in practice and specialty into account, the earnings gap was $25.98 per hour. Women made less in all specialties, with the exception of plastic surgery. The vertical dotted line shows the mean hourly earnings between the matched female and male surgeons. We then looked at the 200 most common procedures across specialties and divided them up into quintiles based on their reimbursement. On the left here, we have the procedures with the lowest hourly earnings. And as you move to the right to the more highly reimbursed procedures, the proportion of women performing these procedures goes down. And because 48.8% of the women surgeons were gynecologists, this finding is largely explained by the poor reimbursement for gynecology procedures in general. When people hear about our study, one of the most common reactions that we hear is that you can't have a pay gap in a fee-for-service system because the schedule of benefits dictates what each procedure is worth. But the process by which the fees are allocated to procedures is largely subjective. As an example, a cholecystectomy is worth $478, while a salpingectomy or salpingo-oophorectomy is worth $306.85. This is about 64% of what a cholecystectomy is paid. We considered other factors that may drive the earnings gap. We found no difference in speed of practice in the operating room. Men and women across Ontario were operating at about the same pace. The one exception was plastic surgery, where women had on average one extra 15-minute increment. This could mean that they could be slower by as little as 1 minute or as many as 15 minutes. I would suggest that speed of practice may influence the earnings gap in other areas. Women physicians have been shown to spend more time on average with patients than men. So there are probably other aspects of practice that disadvantage women's earnings in a fee-for-service system. We couldn't assess billing practices using the available data. And as I've discussed, we looked at the types of procedures which did explain some of the difference, with women surgeons having fewer opportunities to perform the more highly remunerated procedures. And since women within each specialty were generally performing the more poorly remunerated procedures for that specialty, we hypothesized that referral patterns may be driving the earnings gap. There's been some interesting work using US Medicare data to evaluate physician referral patterns. Dr. Heather Sarsons, who did this as her PhD work in economics at Harvard, used Medicare data to look at referral patterns. And she found that female surgeons received fewer referrals overall. And if a patient had a poor outcome after surgery performed by a woman surgeon, that patient's referring physician was less likely to refer to any woman surgeon in that specialty. And that unfortunately illustrates the impact of gender on perceptions of a physician's ability. Zeltzer looked at 100 million patient referrals to 500,000 US specialists. And he found that doctors refer more frequently to specialists of the same gender. And since most referring physicians are male, this drives up the demand for male specialists. And this explained about 14% of the gender gap in physician specialist earnings. We also looked at referral patterns to surgeons in Ontario. And this is a picture of one of my career mentors, Dr. Nancy Baxter, who has made really substantial contributions to addressing gender bias through research. This news article headline summarizes the findings of our study, which is that biased referral patterns show that male physicians refer more patients to male surgeons than to female surgeons. In this study, we explored the concept of gender homophily and referral networks. Inbreeding homophily refers to the tendency to develop relationships with others who are similar to ourselves. In a perfect world, the proportion of referrals that are seen by male and female surgeons should match the proportion of available male and female surgeons. Inbreeding homophily is present when the proportion of male to male referrals exceeds the population proportion of male surgeons. The presence of inbreeding homophily does not on its own indicate bias, because there can be reasons why the distribution of referrals might be different. For example, if it were true that female surgeons are more likely to work part-time, they would be less available to see referrals, and all referring physicians, men and women alike, would have to over-refer to male surgeons. This brings in the concept of a relative homophily, which compares the fraction of referrals to male specialists between male and female physicians. If the proportion of male to male referrals minus female to male referrals exceeds the proportion of available male surgeons, it would indicate homophily. So we looked at over 40 million outpatient referrals by over 44,000 physicians to over 5,600 surgeons in Ontario, and we looked at this over a 20-year time period. Female surgeons more often received referrals for female patients and received fewer procedural referrals than male surgeons. Male physicians had a 32% greater odds of referring patients to a male surgeon, whereas female physicians had a 1.6% greater odds of referring patients to a female surgeon. What we had hoped to see is that this would improve as more women entered surgery, but in fact, we did not see this. Relative homophily actually increased as the proportion of women in the surgical specialty increased. So on this figure, on the x-axis, you see the percentage of women in the specialty, and on the y-axis is the degree of relative homophily. And up here on the right-hand side is gynecology, where we have about 50% female surgeons, and it exhibited the highest level of relative homophily. This suggests that we can't just wait for equity to happen. Gynecology is a perfect example of a specialty where we have achieved equity in the numbers, but the culture, the bias, continues to disadvantage female surgeons. This was a fantastic commentary that is written by Drs. Watson and King, Dr. King at Harvard, describing discrimination against women surgeons and procedures that are performed on women patients. The lower reimbursement for gynecologic procedures leads to many OBGYN surgeons preferentially delivering obstetrical services. This is true in Ontario as well, and this results in many low-volume gynecologic surgeons. This commentary really talks about how the devaluation of women's work can result in lower quality of care for women patients, as surgical outcomes are really closely tied to surgeon volumes. The last thing I wanted to say about the gender pay gap relates to surgeon access to operating room time. During the pandemic, many of us who provide benign gynecologic surgery have experienced a decreased access to the operating room to care for our patients, which has resulted in really profound wait times. In Canadian hospitals, funding for surgical procedures flows through either a global hospital budget or activity-based funding that targets specific procedures. Activity-based funding was introduced to reduce wait times for specific procedures and improve quality of care. But we hypothesized that these funding strategies may have inadvertently introduced bias into what procedures hospitals prioritize, and that the pandemic may have worsened the impact on these procedures that don't fall under any priority strategy. Not surprisingly, we found that body systems that were funded predominantly through global hospital budgets, specifically gynecology and otologic surgery, saw the fewest months at or above baseline volumes during the surgical ramp-up periods. This meant that the least amount of operating time across Ontario was given to these specialties to allow surgical recovery. In contrast, those body systems with multiple activity-based funding options, such as musculoskeletal procedures, abdominal procedures, saw the most months at or above baseline volumes. Our findings suggest that activity-based funding mechanisms may have inadvertently deprioritized certain procedures performed by certain specialties within hospitals, and these effects were accentuated when global hospital budget funds were diverted to COVID-19 care. Decisions around priority procedures, again, are subjective, and intentional or not, procedures for women and by the specialty with the most women surgeons have been devalued. This calls for the need to devise a more equitable approach to managing the surgical backlog that the pandemic has created. To summarize what I've said so far, within Ontario's fee-for-service system, the hourly earnings gap between male and female surgeons can be explained in part across specialties with fewer women in the highest paid specialties and therefore fewer opportunities to bill the highest paid procedures, within specialties, with women performing less lucrative procedures, which may relate to referral patterns. Male referring physicians being more likely to refer to male surgeons, and this tendency becoming more pronounced in specialties like gynecology, where more women surgeons become available. It can be related to the fee schedule itself, which devalues gynecologic surgery, resulting in a high volume of low volume gynecologic surgeons, which can then impact patient care negatively, and further devaluation of women's work and women's health due to hospital funding priorities. I'm going to shift now to talk about my work related to pregnancy and family planning among physicians. So in spite of the gains that we have made over time, pregnancy and parental leave in medicine is still seen as an inconvenience rather than a normal part of life and part of physician wellness and self-fulfillment. Women surgeons are more likely than male surgeons to remain childless, and women are more likely to leave surgical training and experience gender-based discrimination related to parenting. We continue to place the onus on individuals to succeed in a system that historically excluded women and has only recently begun to acknowledge the importance of physician wellness and cultivating personal fulfillment. The motherhood penalty refers to the discrimination that mothers experience in the workplace relative to women who do not have children and to men with or without children. Unfortunately, this is a common experience of women in medicine. It can be overt discrimination, such as being escorted out of a conference because you're breastfeeding, or being told that you won't be supported in your training program if you have a child. It can also be more subtle. One example is being given fewer career opportunities because of assumptions of how career priorities might change when you have children. Women without children experience this as well. Studies show that women are given different advice regarding surgical specialties related to their gender and the possibility of having children and taking leave. Our peers who don't wish to have children are also affected. There are many reasons why physicians might delay childbearing. Training often occurs during the reproductive years. They may experience stigma and disparaging remarks around pregnancy and parental leave during training. They may have fears around lack of support or loss of their clinical skills. They may have concerns about the impact of a pregnancy and parental leave on their career trajectory or referral patterns, concerns that their absence will burden their colleagues. They may be concerned that pregnancy-related complications could result in unplanned time off, and concerns regarding affordable and flexible childcare. To evaluate the delay of pregnancy among women physicians, we performed a retrospective population-based cohort study using data from the College of Physicians and Surgeons of Ontario, which is the sole licensing body for physicians in Ontario. We linked these data to identify physician occupation to their health outcomes. I did these studies with my colleague, Dr. Maria Cusimana, who I pictured here, and she's actually coming to Boston to start her minimally invasive surgical fellowship this fall. In this study, we were able to use these unique data to identify and follow physicians from the age of 15 years onward, and we compared them to high-income non-physicians. This is what our study showed. Physicians initiated childbearing significantly later than high-income non-physicians, with an average age of 32 versus 27 years. On this figure, around the age of 37, you can see that the two lines cross, suggesting that physicians always intended to have children, but caught up at later maternal ages, intentionally delaying childbearing to accommodate their years of training. The other finding from this study was that less than 2% of medical students had children. This suggests that the culture of delay starts very early during medical training. We compared family physicians with other specialists and observed the cumulative incidence of childbirth was higher in family physicians than both surgical and non-surgical specialists at all observed ages. What we hoped to see was that as more women entered medicine, as Ontario improved parental leave policies for postgraduate trainees, that trends would improve, but in fact, they didn't. Women physicians born between 1985 and 1994 had lower cumulative incidence of childbirth at comparable ages than those born in 1976 and 1984. This might relate to extended training pathways among physicians in most recent years, and it probably reflects the still present maternal discrimination in medicine. To explore the culture of delay, we invited final year medical students of all genders to participate in qualitative interviews on their understanding of age-related fertility decline and how family planning may have impacted on their specialty choice. So these were all medical students of all genders at the University of Toronto who had already matched to their specialty. 20% of the graduating class expressed interest. We ultimately interviewed 38 medical students, and we focused the questions on family planning, asking around knowledge of supports in residency, teaching in medical school, perceived attitudes from peers and training programs, and personal goals. During these interviews, the hidden curriculum in medical school that actively discourages students from engaging in family planning was quite apparent. Medical team dynamics and culture profoundly influence the attitudes and perceptions of medical trainees during these very formative years. As you read through these quotes from the interviews, keep in mind that this is not the fault of the medical trainees for thinking along these lines. This is what our medical culture has promoted. Students cannot ask about family planning because they worry it will affect their chances of matching to their choice program. Surgical programs are particularly unsupportive of family building during training. And rather than seeing family building as an important part of life and personal fulfillment, it is often seen as a member of the group letting their colleagues down. We need to promote allyship, and these important discussions have to start early in training. Why is it so essential to physician well-being to start these conversations early? It's because our colleagues are suffering the consequences of delayed childbearing. In this study by Stentz and colleagues, they surveyed physicians to understand how common fertility may be among women physicians. They surveyed 600 women physicians who graduated between 1995 and 2000, and among the 1 in 4 physicians who reported a diagnosis of infertility, many wished that they had attempted to conceive earlier, had gone into a different specialty, or frozen their eggs. On the right, there's another great study out of Harvard. In a study of 692 female surgeons, 42% experienced early pregnancy loss, and the majority of them took no time off work after suffering their loss. About a quarter of the respondents used artificial reproductive technology, highlighting again that physicians do appear to be at an increased risk of infertility, likely related to delay of childbearing. Some other important numbers to highlight from this study: 56.6% of respondents worked more than 60 hours a week during their pregnancy, 22% took time off for bed rest, and 16% were taken off work for an obstetrical indication. Using our same population-based linkage, we evaluated physician pregnancy outcomes. Certainly, physicians may be at an increased risk of adverse pregnancy outcomes due to the nature of their work. The available literature on physician pregnancy outcomes is actually quite mixed. There are some cohort studies that demonstrate worse outcomes for physicians, such as preterm birth, hypertensive disorders of pregnancy, and small for gestational age infants, while others have found no such association. Possible reasons for these worse outcomes may relate to age-related complications, because physicians do tend to delay childbearing, working long hours and overnight work, exposure to pathogens and radiation in the workplace, and the physical demands of being a physician. We compared births among licensed physicians to births among high-income non-physicians. Our primary outcome was severe maternal morbidity. This is a composite outcome that reflects adverse maternal outcomes on the continuum to maternal death. Some are diagnostic indicators such as severe preeclampsia, and some are procedural indicators such as peripartum hysterectomy, and these all occur within pregnancy or up to 42 days postpartum. We evaluated the outcomes of interest in an unadjusted analysis, and then we adjusted for other important factors, and finally, these factors plus maternal age. In the unadjusted analysis, physicians were more likely to experience severe maternal morbidity and preterm birth. But once you adjusted for age and other factors, the difference disappeared. This suggests that the adverse outcomes observed among physicians is actually related to later maternal age at childbirth. To explore the impact of work-related factors on outcome, we compared outcomes of family physicians to other specialists and divided them into surgical and non-surgical specialists. The outcomes were not significantly different, but I do want to point out that it is extremely difficult to look at work-related factors and its impact on pregnancy outcome using administrative data. You can't tell if somebody was taken off work for an obstetrical reason, and maybe this improved their outcome. And teasing out the amount of time worked at each stage of pregnancy is very challenging. While we found no significant difference here, I do think that much more work is needed to understand the impact of work-related factors on physician pregnancy outcomes. I'd also like to emphasize that egg freezing is an amazing technology that can be used as a workaround to avoid infertility if a physician chooses to delay childbearing. However, it will not overcome age-related pregnancy complications. Excuse me. It is an option, but it should not be the only option. I participated in a podcast with the CMAJ to discuss parenthood in medicine, and one of the hosts said something that I thought was really quite insightful. He said, egg freezing sort of parallels the discussions over burnout and how resiliency was brought up as a solution to burnout, which really was just about getting people to be able to handle the system instead of changing the system itself. We still have a long way to go. Rather than continuing to ask women and people to adapt their family planning to the historical culture of medicine, We have to start working to shift that culture. We need to stop putting the onus on individuals to figure out how to get by in a system that really doesn't support them. So for the rest of my talk, I want to focus on what we can do to promote change. These are two of my colleagues who have been really working to champion change from an early career stage. On the left is a photo of my colleague, Dr. Fahima Dosa, excuse me, who has spearheaded the work we've done in evaluating the gender pay gap and referral patterns in surgery. We started this work during our graduate training together, supervised by Dr. Nancy Baxter. When we were approached by the media to be interviewed about gender bias in medicine, to be honest, I was too worried about backlash to participate. I am so glad Fahima did participate. The trouble with not speaking out, and the reason why this research is so important, that is that if we don't have these difficult discussions now, we will be having the same conversations in years to come. And along the way, we will lose talented individuals. And losing a talented physician who has invested years of their life to training because the system does not support them is a tragedy, both to the individuals, the patients we serve, and the medical system as a whole. On the right is Dr. Shirin Dason, who's been a relentless advocate for family planning for medical trainees. She's a reproductive endocrinology and infertility fellow here at U of T. Her work in creating resources and advocating for support for medical trainees in this space has led to engagement of medical training programs across Canada, and I'm going to share some of the work our team has done. So how do we move forward? First, I think we need to acknowledge the long way we need to go to truly achieve equity. There are broader societal structures at play, and while it might not be possible to change all of society, we need to think critically about how we can improve equity within the institution of medicine. The pay gap reflects systemic gender bias in medicine. It is concrete evidence. It starts early in a woman physician's career. The hidden curriculum drives women toward lower paying specialties, and within each specialty, women make less, which is driven by referral patterns to an extent. Other literature shows that women spend more time with patients, and patients may also hold female physicians to a higher standard in terms of empathy and time spent with them. This can also adversely affect salary in a fee-for-service model. Gender bias affects women at all levels of their careers. Women are often seen as disruptive or difficult if they negotiate. They are less likely to be given career opportunities. The larger societal biases on delay of childbearing and parental roles may not be something we can fix, but we can work toward this. And I'd like to emphasize again that this is not something that can be solved at an individual level. It requires commitment from leadership. There's no easy solution. If there were, there would be no gap. The hidden curriculum needs to be addressed in medical schools early in training. Rather than pushing women toward family-friendly specialties, all training programs should address how we can support individuals of all genders, including the provision of pregnancy and parental leave. When physicians start their practices, hiring process and negotiation should be transparent. Physician pay is often tied to the resources that a physician is offered when they start working in the hospital setting. We should not leave it up to individuals to know what things they should be negotiating for. Since there remains a gender gap in leadership, women should be supported, mentored, and recruited into leadership roles to ensure representation. Organizations should critically evaluate pay equity, and physicians should have an equal distribution of unpaid work. For surgeons, centralized referrals has been proposed as a way to ensure equal distribution of surgical referrals. This may be a solution in some settings, but I think overall transparency is important. To support family building during training, we are working with medical schools across Canada to propose solutions to reducing stigma and supporting trainees who wish to be parents at any career stage. Some of the strategies have included developing a specific parental leave policy for medical students outside of sick leave, building lectures into medical school curricula on age-related fertility decline to foster allyship, developing a training kit for career counselors to foster conversations about family planning with individual students, creating accessible information for family planning education and resources at all levels, and improving support for residents returning to work after having a child. So some flexibility in scheduling and childcare, maybe not coming back to the most difficult surgical rotation. Based on what we learned from the medical students that we interviewed, we built a team and created a website to support family planning for medical trainees. The website's been designed to provide accessible information on things to consider with respect to family planning and building at each career stage, and to create a mentorship network, as the role of mentors was identified as being particularly important to early stage trainees as they consider their career path and family plans. The website link and the QR code are here. This is available on the website. It includes some key questions that all trainees should be thinking about early on. We have found that when we speak to medical trainees about age-related fertility decline, they are often aware of it from their medical training, but they have difficulty thinking about how this specifically applies to them in the context of their careers and training pathways. And this is a recent publication in the New England Journal of Medicine that highlighted one of the teams leading change in this area at Harvard, the Society of General Internal Medicine's Women in Medicine Commission, that's working to support trainees throughout pregnancy as well as physician parents. If you haven't read this piece yet, they outline their own personal challenges that they faced in combining residency with family planning, current gaps in policy implementation, and the work they're doing to directly support trainees in programs, recognizing the slow progress in changing medical culture as it pertains to pregnancy and parental leave. Changing culture is hard, but it is possible. In 1973, interns and residents in Ontario went on strike. They wanted a pay raise for the amount of time they were working, and they wanted an end to 1 and 2 call. Dr. John Crosby wrote about this time how staff were working 114 hours per week and were on call every second night. One old surgeon said the only bad thing about being on call 1 and 2 was that you missed half the cases. Think for a minute about the culture at this time. Isn't this what you signed up for? Why can't you handle 1 and 2 call? This is what we did when we trained. Looking back, everyone today would agree that 1 and 2 call was simply dangerous. It was bad for physicians and their families, and it was bad for patients. But we had not yet accepted that lack of accommodation for trainees who are pregnant and postpartum bears a similar resemblance to this mindset. Isn't this what you signed up for? Why can't you be on call during the late stages of pregnancy? Taking time off is unfair to your colleagues. All physicians are deeply aware of their social responsibility to patients. This is what we signed up for, but it doesn't have to come at the cost of personal wellness, fulfillment, and longevity. Because if you allow doctors to look after themselves and foster a culture of self-compassion and compassion for fellow physicians, they can provide better and more compassionate care to patients. So how did the doctors' strike end? After 2 weeks of working to rule, PARO, the Professional Association of Residents of Ontario that had been founded several years prior, won the arbitration. The result was much more humane hours with time off after call. And since that time, for the last 60 years, PARO has enabled resident physicians to have a voice in their working conditions and pay in Ontario. Their advocacy has resulted in protection for pregnant residents, no overnight call past 27 weeks gestation, as well as pregnancy and parental leave policy that is congruent with our provincial pregnancy and parental leave allowances in Ontario. Every medical resident is a member of PARO, so the policies are ubiquitous across all training programs in Ontario. We are really fortunate to have come this far in Ontario, and even though the culture of dissuading trainees from engaging in family planning still exists, there's protection for residents who wish to become parents. And maybe, until the culture really changes and maternal discrimination is a thing of the past, this will prevent some of our colleagues from suffering the pain of infertility and adverse pregnancy outcomes and being ultimately more satisfied in their lives and careers. I thank you again for inviting me to come speak today. Fostering systemic positive change in medicine to support physicians who want to have children at any training stage will promote wellness and career satisfaction in the long term. And I hope that I've shown you today that pay equity and the provision of pregnancy and parental leave are not only essential to physician well-being, but also to the well-being and care of the patients that we look after. Thank you so much.
I was saying, bravo, Dr. So that was unbelievable. Really, you hit on so many things that I would love to reiterate, but I do want to leave time for questions, and I do see some coming into the chat, but thank you so much for bringing this to us and for all the work that you've been doing to bring data to the question and bring data objectively, which I think is so crucial. So I will turn to the chat. Again, people are welcome to put questions in the chat or direct message them to me, but there's a question that has there been any measurement on decisional regret in regards to family planning or specialty choice adjusting for external factors like spouse's profession or proximity to family?
That is a great question. I am not aware of any studies that have specifically looked at those factors, but I do think that that is an area that needs to be looked at some more. I think another issue like specific to women physicians is that we are often told or encouraged that if we don't leave our training centers to go learn skills elsewhere and come back, that we won't be as competitive for jobs. And it is really hard to leave your training center and your family and supports and start a family during those years. So I do think that this is a great point that you've made, and definitely needs more research.
Great. And there's a little bit of there's a comment here about how things maybe haven't changed as much from a show that aired in 1963. But I do appreciate, how you were sharing Dr. Crosby's sort of march from 1973, I think it was. But I don't know if you had any further comments about maybe change being a little bit slower than some of us are kind of feeling, like hoping maybe it goes a little faster, shall we say.
For sure. And I think often there's that sentiment that like, oh, we're just exactly where we should be. Like change takes time. It's just going to, it's a pipeline. It's continuing to take time. But I think we have, data to support that it's not a pipeline, especially with some of the things I was showing with the gender pay gap. And as more women enter a specialty, we actually see more relative homophily. So I don't think it's a pipeline. I do think that we really need to actively think of ways that we can get more women into leadership roles and try to move change forward more quickly.
Thank you so much for that. And then a great comment question here about today you're presenting predominantly to maybe a female audience, and I'm assuming many of us join this call because of a personal commitment to gender equality or just because we have suffered from some form of gender bias maltreatment in the workplace. How do you infiltrate male population / stakeholders who may not be as open to hearing this information in order to advocate for change?
Great question. And yes, I think sometimes that it is a predominantly female audience, and we are all here because we've experienced these things, but it really is hard to get to leadership and to get to other stakeholders who are not female. I think trying to get more women into leadership roles, I think ultimately will be instrumental in changing culture. Some of the work that I presented in gynecology circles, I've really tried to show the men in the room who have committed to women's health as well, how this is impacting on their ability to care for patients, because it's not just women surgeons, but it's care for women patients. But it is an ongoing challenge to try to get more commitment from leadership to acknowledging and changing these things.
I just put in a plug. You mentioned a couple times, Dr. Simpson, about allyship, and we in the Office of Women's Careers here at Mass General have been working on an allyship program for men, specifically directed to hopefully increase allyship and just really awareness of some of these issues across our male colleagues. But welcome any and all thoughts and feedback on that from anyone in the audience. Casey, I see your hand is up. Can you unmute?
Yeah.
Great.
Dr. Simpson, thank you so much. We here at MGH are really big fans of your work and have read everything you've ever written and quote you often. So your H index is going up solely because of our research group. So I was just noticing that there are many women here at MGH and Harvard affiliated hospitals. I know several women in San Francisco and some in Philadelphia and your group, and we all are publishing similar work and we're all interested in achieving the same goals. And yet when I proposed to do a breakout session at the American College of Surgeons or some of the pediatric surgical meetings that I'm a pediatric surgeon. I've proposed for the last 4 years to do some of these. I've actually invited some of your colleagues and we've been turned down every time. And although I'm seeing more and more talks about the gender pay gap and the differences in work equity and pregnancy complications, I feel like we're not getting traction in the higher echelons of the work environment where we might be able to make change. And one of the reasons is because those people who are needing to change and needing to actually have something to lose are older male colleagues. So how do we band together and become the resident physician group that push forward the pregnancy work hours, or how do we go on strike like those people did in 1973? Like, how do we advocate better for ourselves and really get something started?
Great question. And yes, I think there's a lot of people doing really excellent work across Canada and the US, and we should be collaborating more. So I'm sorry that you've had those experiences in the past trying to promote collaboration. I would be very happy to meet offline and talk about some collaborations with you as well. I think that this AK scholarship is a great way to network and meet people as well. But Yeah, I think that there strength in numbers and being able to work together to get this this work recognized by the people who really need to see it is important. In any way that I can facilitate that, I would be very happy to.
Great, thank you. And Jan, yeah, I just saw your note in the chat. You want to unmute and ask your question? Thanks for being here.
Sure. First of all, Dr. Simpson, thank you for a really important and just beautiful presentation, both very evidence-based, but also really personal. It was very powerful. So as an REI, you did mention oocyte cryopreservation. It's clearly a great option. Glad we have it. Your biggest concern was that women would be older when they were pregnant and have, more pregnancy complications. But it's just so important for women to realize egg freezing is not a guarantee of pregnancy. And, the first thing I say to any woman who comes to see me, and we're seeing a lot of women for consults, is if you really want a baby, you have to have a baby with your own eggs. There are always options later in life, someone else's eggs, but if you really want a child with your own eggs, just go for it. We talk a lot about single mom by choice. So I think there is a misconception out there that, I've got my dozen eggs in the freezer. Whoo, now I can do my cardiovascular surgical fellowship. But those eggs may not result in the pregnancy you're hoping for. So I think that's really important too. And thanks again. Great presentation.
Excellent point. Thank you so much, Dr. Shipron.
Great. And then there's a comment or a question here about just some of the specifics around pregnancy leave. I'm not sure. I know you're in Canada, but if you had any sort of thoughts about parental leave, we've had some changes here in the US, but.
Yes, so the US is quite different from Canada and Ontario. So for residents of Ontario who take parental leave, it's actually 12 to 18 months. For physicians through Paro, pregnancy leave is 17 weeks. And then parental leave, it adds an additional 35 weeks or so, or you can go for an extended option, which is 61 weeks in addition to your 17 weeks. So I do realize that that is quite different from a lot of jurisdictions in the US. I see that my jaw just dropped. Yes, I do think that we have to acknowledge, what a good system we have here in Ontario as well. And I often wonder, as I present the data from our studies, how different the results would be if it was replicated in a US setting, because I'm sure that it's more of a deterrent to trainees to take parental leave if they know it's going to be a very short leave. And I see the note here, is it paid weeks? Yes, it is paid.
I just had a question about, I was so intrigued by how in gynecology, as the sort of rates of women surgeons increase in the department, that is it homophily increased?
Homophily. So
homophily, thank you. I know I was mispronouncing it. I just am trying to understand that a bit more, because that's really the tendency to sort of be attracted to individuals of similar traits, right? So you have more women. How is that sort of happening when you have more women in a department? I'm not quite sure I'm understanding how that's increased.
Yeah, so I think primarily when physicians or when patients get a referral from their physician, they ask their physician to recommend somebody. So every so often you'll have a patient who will research a physician and say, I really want to see this one person. But for the most part, it's patients going to their physician saying, I'm recommending this surgeon. So we found that more commonly the male referring physicians were referring to male surgeons, and that this association was the strongest when there were specialties such as gynecology, where there was many women surgeons available.
See, Leland Hull's hand is up. Leland, do you want to mute?
So I just wanted to thank you so much for this talk. I also had the decisional regret question about external factors. I just wanted to follow up to ask about when, there was some discussion in both parts of your talk about kind of counseling and opportunities that may or may not appear to women physicians and surgeons, and maybe some of the counseling that they may get around either family planning, specialty choice, et cetera. And so, has there been any look back at, how that counseling is perceived pre and post kind of family planning, actually having children, and kind of, what changes people may how people may interpret those things differently. Just, I guess to clarify, so for example, if somebody said, you know, you may want to consider that other specialty because this is going to be a hard road for you if you want to have a family, and you're in med school and feel very offended by that, has there been any look back at, well, maybe I wish that I had gone down the anesthesia route now that I've actually gone through it?
Right.
And so kind of, again, qualitative data around decisions.
Yeah, so in the study that we did with the medical students, we're doing a follow-up study now to look at residents to see, like, you know, once they're a few years into their specialty, to see if there's any difference in the way that they are thinking around family planning compared to the medical student level. I would say, like, the medical student years are extremely formative. Like, medical students are very much influenced by what they are told and what they see around them. We had some participants in that study who, you know, found a mentor that they really got along well with, decided to go into that specialty. And I think in one situation, the mentor was like, I think you should have your children in medical school. It'll be easier than residency. So they did. So I think that like mentorship and the signals that the medical students are getting from us really plays a big role. And I think that also when you are told these things during your medical training, even if you say, like, I don't agree with that, I'm going into that specialty, even though it might be harder, I think that you are always sort of in your mind, like, there's always that kind of background thought that maybe they were right, maybe I shouldn't have done this. So I think that we really have to refrain as physicians from maybe imparting some of our own feelings about, you know, what we think somebody wants in giving them advice. I saw an article recently where I think they called it benevolent sexism, where they say, oh, like, you should really consider that family. It'll be easier for you. But I think that we need to stop being so directive with our counseling with medical students and rather allowing them space to explore these different options. And I think the other piece of it is that it's all such a black box to them. This is what we found and why we created the website, because they don't really understand, like, when I'm a resident, how much money will I be making? And how much does childcare cost? And so forth. So we're trying to remove some of those barriers to them just understanding what their life might look like, and depending on when they would like to have children.
Thank you so much.
And there's another tricky question, which may depend a bit on what institution you're at and where you're living, but residents and fellows are significant workforce caring for patients. How do we adjust for time off for family and still provide care? What is being done in Canada? Yeah, so I think that this is very variable depending on what training program it is and how many residents are in each training program. It certainly, if it is a smaller training program, the impact of somebody going on leave is felt much more by their colleagues. I do think that we need to start thinking of some more creative solutions to this. During the pandemic, PARO did bargain for some additional funding for residents who had to take additional call because people were off sick with COVID. So if a resident was off sick, another resident would have to come in and do extra call for that trainee. And they were paid more for doing that extra call. And I found that it actually took a lot of the resentment out of that person having to come in. It wasn't like, you know, I've been let down, I have to come in to cover my colleague. Instead, it was like, well, here's an opportunity to make some more money. It's not going to happen to me down the road, and someone else will cover for me. So I actually do think that if we thought a little bit more creatively, maybe we need to advocate for expanding residency program sizes, now that knowing that, you know, 50% of the people in medicine may decide to take parental leave at some point. It might be more if we start seeing men taking parental leave as well. So I think that these are higher level things that may not be easily addressed, but I do think that there might be some creative solutions like this pandemic pay that the residents got that we could consider. Fantastic. Well, let me just take the last minute here to say thank you again. This was an outstanding presentation. As so many of our colleagues already said, it was data driven, it was thoughtful, and it just goes to show you're really leading in this space, which we really need. And I love your awareness that culture and systems need to change around the individuals doing the work that they're doing. And so really appreciative of your work, and thanks for leading us and for being here today to talk with us. Greatly appreciate it. Thank you again. Take care, everybody. Thank you.